Hi, good afternoon, everyone. Can you hear me?
Yes, I can hear and see you.
Yes. Happy New Year, Joy.
Happy New Year.
Happy New Year to everyone who has joined so far. Do we have all the doctors? Good afternoon, Dr. Shiv Kumar. Thank you so much for joining from your holiday. He's on a vacation. We will wait for a few minutes. Good afternoon, Rahul. Can you hear me and see me?
You're on mute.
Yeah, good afternoon.
Yes.
Good afternoon.
Hi. Happy New Year.
Happy New Year. Happy New Year to everyone.
You know, Dr. Sujoy, Rahul.
And a lot of childhood memories.
Yes, and his father is an amazing pharmacology professor. And I would not have cleared my second MBBS exam otherwise. One of the toughest subject, pharmacology. Uh, I think we'll wait for a few more minutes and then try back. Good afternoon, Dr. Shiv Kumar. How are you? Happy New Year.
Good afternoon. Very happy New Year. Good afternoon to all of you.
I am so honored, or I'm so proud of the fact that we have all come together today afternoon to do this very interesting discussion. And I think we can start. People can join us. So let me, yes, because this is such an interesting discussion which we are going to transcend barriers from uh, existing clinical scenarios and stratification to something which is beyond our imagination. Uh, Welcome one and all to another Wednesday afternoons of ProHealth Talk. And I'm really very, very happy to kick off our 2024 with brilliant, technology and combination of brilliant technology and clinical scenarios. Thank you very much, Dr. Sujoy, Dr. Shiv Kumar, Dr. Rahul Gupta, and Dr. Vijay Kumar to have joined us on this panel. To begin with, I am going to just quickly run us through how we are doing the existing AI CBD risk, which has been devised, which has been calibrated by our panelists, and how it reflects in the Med Mantra, how we are using it today. And this is just going to be a 5-minute presentation by Vijaya here, and then we will start with the discussion.
So we're just sharing with you one of the profiles, the guest profiles, the base. So this one is showing you all the. This one is showing you all the various parameters, the mandatory parameters needed for generating the AI CBT score in our MedMantra platform. That is the health check summary. Okay, if you can. So this is the screen that you can see, which has the cardiac risk score, the AI CBD score that's embedded into all of our health checks. Once the 14 mandatory fields are captured in the system, this score is actually automatically generated and displayed on the screen here. Now, for this profile, you can see the risk score generated is a moderate risk score, and the top risk contributors are also listed below. And for the physician, as a physician, if you want to go and look into more details, then you can go into this section and you can click on this AI CBD score. And when you do that, you're able to see this report that gets generated. It basically summarizes all the parameters that are captured. It shows you the AI CBD generated risk score, what is the acceptable score for that guest, and what are the various risk factors in this. As you go down, you can also see what are some of the recommended protocol, and the clinical team will walk you further through this. This is what the physician can see and put in your recommendations accordingly. The guests themselves will also, after the summary is closed, will get the digital report through WhatsApp. And in that also the AI CBD score is actually embedded. And you can see the same information, but presented in a simpler context for the guest to understand and discuss with the physician.
Okay. Thank you very much, Vijaya and Nandini. It was really crisp, and I had to literally understand how the Med Mantra works and how we are doing. It's an amazing piece of work by Dr. Sujoy. So to start the discussion, like, how did we even think that this is an ask of the time? I mean, we have the conventional American Heart Association cardiovascular risk score, which we are using globally everywhere. This is how it is going. Why did we even think that this is something which we can integrate into our Apollo ecosystem and use as part of the preventive health questionnaire history? Where did this all start, Dr. Sujoy?
Thank you, Srividya. I have three of very eminent cardiologists sitting here in the panel. In many ways, my guru, Dr. Shiv Kumar, who would tell us why, and I can only talk about how. But I also want to, bring in Dr. Rahul Gupta. Dr. Rahul sir was also one of those eminent cardiologists who actually, started the whole journey towards AI-CVD about 4 or 5 years back when we were there in Mumbai talking about how to get it through ethics committee. And my dear friend Vijay actually joined the bandwagon only about last year with a lot of futuristic thoughts about where we can take this risk. Risk score. So the first thing that I would talk about is how, and I will be very short. We looked at health check, and one of the predominant aspect of what we have been doing over the years in our health check is the profound data that we have been collecting, and in a very accurate fashion. Of course, there are always challenges with data collection, data processing, and all of that. So we started with about close to 400,000 health check reports between 2008 and 2017. And then they looked at also corresponding 60,000 cardiovascular discharges, which were showing us how many of these people who would have had a profile done through health check prior would have had cardiovascular event in the span of next 5 to 10 years. Of course, the period was in 10 years. And then, of course, the other cohort of people who had similar risk factors but never had a cardiovascular event. That is how we have gone about in preparing to cohort and then use lots of statistical methods, correlation coefficient, propensity matching. I won't go into that. The paper is going to be out either today evening or sometime this week, and we can all share about that. But one of the most important aspect was then to look at it from a cohort that was more in Western India and southern part of India, and then go about invalidating the model with Northern Indian population and Eastern Indian population, and then seeing how well they perform over a period of time. And we found a pretty good accuracy in actually predicting cardiovascular disease risk over a period of time with those factors that we could find from machine learning were important to take in. Now, there was nothing, which was completely out of the world. A lot of people who work on this space, preventive cardiology, or for that matter, cardiologists always knew what were the risk factors. So what we did differently was to actually apply the machine learning, make it much more comprehensive, get into the ways by looking at the different kind of population, different age factors, and calculate it as a relative risk, looking at every individual's risk of developing cardiovascular disease at one point of their lifetime. How does that work? And that's how it is today now being rolled out and, looked at. We got it, validated through other institutions across the world. In India, we were supported by King George Medical University. Outside India, Maastricht University, it has now been rolled out in Imperial College London and several other institutions, including MOH Singapore, and where we are now getting more and more dynamic data to build it well. However, the story is just beginning. It is about that we have got in now the last 5 years of prospective use of this. We need to correct thresholds of certain areas where we have to look at, are we overdiagnosing people? Are we underdiagnosing people? There are a few questions that are there in mind. How does it work in different conditions? Which, of course, Vijay will talk about in his area. Just don't want to take the thrill out of his talk. But the factor is, this is a comprehensive journey of building an AI CVD risk score, primarily for Indian population to begin with, and then make it global in that way. I'll stop here, and I would like to hear from rest of all of you.
Yes, thank you, Dr. Sujoy. I mean, I know it has not been an easy job because we are looking at a very highly technical platform and trying to merge it with existing clinical data or our genetic risk scores. So I would like to ask Dr. Shiv Kumar here, sir, how do we compare these two? Like we have our traditional family genetics, and not every family person has not every person has a family history of coronary artery disease, but we are seeing more and more younger people coming up with coronary artery disease. So how do we compare these two places? Like how the AI risk score and the traditionally calculated risk score compare? At what level can we say, okay, we are good here?
Okay, thank you so much, Dr. Srividya. And then I'm really excited, and at least Vijay, hi, how are you? And long time. I'm so happy that at least now we are discussing amongst our colleagues and a lot of our people who will eventually implement it. I feel like telling so many things, but I primarily feel that the doctor fraternity or the medical fraternity needs to change its mindset. If we can have a little flexible mindset regarding AI, probably the adoptions will be much better, and then practical usage of AI would be much better. AI is considered by a lot of our colleagues as a threat, but I think it's absolutely unfounded. It's more like I would always say it's an assisted intelligence, an augmented intelligence, or is a co-pilot, but it's not going to replace. One thing I would always say that AI will not replace the doctors, but doctors with AI will definitely replace doctors without AI. So I feel that the AI is not a push, but probably the adoption. Now, coming back to your point is that's the main thing is I feel that most of the medical research in the last 100 years, 200 years, all those things, we basically, how do we do? We have a hypothesis for any diagnosis for any disease. And then we try to find out the variables, what are the risk factors. And then we use the statistics, the regression analysis normally to see the cause and effect relationship. And that's how we somehow prove the hypothesis which we have brought it out for any new diagnosis, for any new treatment. That's how the medical research has been in all these years. Fortunately, AI doesn't work like that. So we have to come out of this mindset that there has to be a hypothesis and there has to be this result. That means if there are 5 risk factors, only those 5 risk factors are responsible for this particular outcome. So if we can come out of that shell, probably it will be much easier for us to understand how AI operates. So although you may see that the first risk score, what we have, the risk factors, they seemingly look the same what they were there in other traditional risk factors, they are there. But outcomes are different, AUCs are different. The very reason is that in normal statistical regression analysis, you normally do a very, it's a non-parametric, basically the correlation between the variables. Whereas in AI, it goes beyond that. So interrelationship between the risk factors in a particular given situation, if you really start seeing that, will not be able to be possible to do with a traditional regression analysis. So coming back to the point is the AI would help us in generating and predicting more outcomes with a set of risk factors which are already there. And if we can add on few more, then maybe the results could be much more different.
Great. That means if I hear you correctly, what you are saying, sir, is that at this juncture, it is important that we use AI smartly to overcome the shortcomings of the traditionally calculated risk factor and ensure that. So, for example, I think when we started this AI journey, at least like till a year back or 6 months back, there were some like there was some mismatch between the clinician generated AI and the AI generated. I mean, clinician generated cardiovascular, whether it is somewhere it says moderate risk score, but the clinicians consider it as high risk score. So we had this to and fro with Dr. Sujoy, and then we decided that it is not low risk. There is no risk. There is a risk. It depends upon the individual doctor whether you want to consider it as a moderate or as a severe. So my next question is to Dr. Rahul Gupta, that how are you going to take these risk scores which we are giving you through the health check? So a physician has done a health check. They have found it to have moderate risk. One person has it high risk. And this is on the basis of a basic history like we showed in the health risk assessment, and some lab values. The cardiological assessment of echo and TMT is still not there in these risk score. So how will you predict the outcome of these patients? How will we go ahead? So this patient has come to your OPD saying that, okay, I have a moderate risk score as per your assessment. How do I take it up from here?
Right. So first of all, thank you for having me here. And I think it's very important. All of us are making very valid points. India is already world capital of all possible cardiovascular risk factors, whether you say diabetes, pre-diabetes itself is a risk factor for major cardiovascular diseases. Hypertension is on rise. We are seeing so young patients. I think school going, I just heard about one of my friend's daughter whose HbA1c is 6.2. She's just 14. So I think we are seeing epidemic in a large proportion in our country, and I think we are looking for tools which can help us to stratify our patients correctly in our busy practice, where we have this augmented intelligence or artificial intelligence to help us. And I think that job is wonderful, and this is now more pertinent and more applicable to our Indian patient. That is the most important thing, which I think is important. So as coming to your point, somebody has come with, say, moderate risk or high risk. My approach to this patient is going to change, because these are the patients who are apparently healthy. So they are just coming for health checkup because they don't want to develop future events, and they are considering themselves apparently healthy. But if I find somebody who's in high risk, my communication, my aggressiveness in telling them about the lifestyle changes, about further evaluation is going to increase in high risk patients, as well as for example, if you look at the Lipid Association of India guidelines, where in very high risk patients to even lower than 30 milligrams trying to achieve in patients who are extremely high risk on their coronary artery disease risk factor. So what I'm trying to emphasize here is that if I get somebody who is high risk, my aggressiveness in managing all the values, whether it is the sugar control, control, lipid profile control, the values, the target which I want to achieve, will be much more aggressive. And I think they're monitoring also, not only once in a year, but maybe little, maybe 3 monthly, or based on their reports, I'm going to do that. So it's definitely is going to be very useful, because, I will tell you the practical problem. When we are seeing, say, 30 patients, 20 patients, we are doing some procedures in the lab, patients are waiting outside, and we are just cursorily looking at the report. Apparently, it looks okay. But when we go through this AI-based risk score, it tells us, no, this is some red flag to this patient, give some more time, explain it to them properly. So I think it's going to be tremendously useful, provided we are going to apply to our patient population. So I think this has been a wonderful journey and wonderful job done by all those involved. And I think it's once we start applying it more routinely, it's going to be very, very helpful for all the patients whom we are treating, who come with a lot of confidence and trust to us that we are going to take care of their health.
Thank you, Rahul. I mean, I get it that it is, like I said, it is important that we use it smartly and to hasten our diagnosis or prevention. So my question to Dr. Vijay Kumar is that how can we use these AI risk score to personalize our patient journey? Like, in the sense, there are people who say, am I not too young to have a heart disease? But your AI, this score is showing me to be low. But I mean, this is a place where I want it to be low, but it is low. So how do we take it up from here? I mean, how do we personalize healthcare? How do we personalize our cardiac risk stratification with the help of AI?
Yeah, I think thank you so much, Dr. Srividya, for the invitation. And it is a tremendous work done by Dr. Shivakumar and Sujay and group. And I think so far we never had any population specific. You see, there are so many risk
Yes.
scores we have, which is either US based, European multiple. Either you have UK and rest of Europe have different score. Even China has a good score, a population based score, which can be, and Australia has one. But so far, we never had one. We use QRISK 3, that is one closely related to us because that included some of the Indian population. But AI-based is one of the most important things to happen in maybe primary prevention of in a country where we have huge number of population who need it. And as already Dr. Rahul was telling about a 14-year-old having 6.2, that is not rare at all. And if you just screen 20-year-old people, 100 people, you'll be will be getting similar results in 20 of them. So that is how it has become an epidemic now. I think that is, in that scenario, this type of scores, particularly this AI-based score, will make a huge impact. But again, moving forward, and this is a basic score, but there's a tremendous work has been already done to establish a base for this thing. And there is a lot of scope for future research with this thing. And we are already discussing about including some subclinical atherosclerosis imaging. And you are talking about somebody supposed to be low risk, may not be low risk. There is a small possibility that they are not low risk. And sometimes you feel hypertension, diabetes, dyslipidemia. All these things per se doesn't mean anything because we have seen patients, even the last 1 month, I've seen 3 or 4 patients with more than 200 of LDL and still pristine coronary arteries. There is absolutely no disease. And again, Dr. Sekumar was talking about cause and effect, means cause and effect relationship. So that again, that is the next step forward, moving forward with that. So still, if we say that mild risk, moderate risk, and high risk, that is mainly to focus on your primary prevention treatment and lifestyle modification for everyone, whether they have to take statin, whether they have to take ecosprin, that is the thing we are looking into. Suppose somebody moderate risk and they don't want to take, how do you convince them to take your statin and other things? That is where the next step comes in. So some form of atherosclerosis imaging, whether you do a carotid Doppler for looking for plaque, you do a femoral Doppler looking for a plaque, and they do coronary calcium score. It may not be very valid in very young population, maybe anybody more than 40, and you can still use these things. But still in young population, you can do carotid screening, femoral screening. So these are the things has been shown to happen very much more earlier. So it is all start by age of 20. So when you find something and you find some other risk such as hyperlipidemia, you find diabetes, hypertension, that is where you treat them very aggressively. I think there's already, I think a lot of work has been done. We should be getting some exciting results in near future.
Yeah. So thank you, Dr. Vijay. Let me at this point also bring out something that I mean, though we are kind of very proud that India is coming up, the GDP is improving and all, but we are also increasing our healthcare cost. We are increasing the healthcare burden on individuals, and not a very insurance-driven society even today, right? So when we talk about personalizing these investigations, I think it goes a long way in assuring that, okay, hey, in a scale of 1 to 100 or 1 to 10, you probably are at 3, 4, and we can prevent it and make it stay there, That's how. So I also understand, yes, I'm coming to you, Sujoy. This is very, very interesting question which I'm going to ask you. You be aware now. So tell me something. When you started this journey, you must have started with a set number of parameters, maybe age, family history. I remember, if I remember correctly, you decided not to include the past history of coronary artery disease in the scoring. But then now we have kind of made some changes. So what were those 4 or 5 inclusions which you took in in your first round when you started working on the AI. And I think now when we are talking to everybody, you are going to have to add many more to this list soon.
Right. So I just want to bring a perspective here, Dr. Srividya. And this is again from many of my discussions with Shiv sir, and then of course with other cardiologists as well. Say today we are having a set of parameters that individual has, whether it is dyslipidemia, high BMI, or one or two other factors, and all of that. And say the patient comes and sees Dr. Rahul in Navi Mumbai clinic. And sir then goes about giving him certain prescription, lifestyle modification, and others. And 3 months down the line, he comes with a lower BMI, much controlled blood pressure. His lipids are now controlled, right? Which obviously, if you put it in a mathematical equation or in a computation, you would see that the risk is now lower. It may so happen that the person who was at a high risk has now gone into moderate risk, or people who was at a moderate risk has gone on to low risk. Now, here is the question. Now, when you decrease those parameters, and then you are now becoming seemingly healthy, what is the effect? Or what is the effect that it has on overall mortality in next 5 years or 10 years and 15 years? This is exactly what we are studying. We call it as a counterfactual or causality, where when you change your lifestyle, when you modify your risk scores, what effect does it have on an event or on mortality and all of that? This is something which we cannot go retrospective and study. This is something we have to do prospectively, and this is going to fine tune your model. Now, we had a tremendous amount of discussion with Maastricht, with KGMU or AIMS when we were actually doing this, of course, internally with Apollo as well, all in Chennai, Ahmedabad, many centers in Delhi as well. One of the questions was this, that why haven't you taken pre-existing coronary artery disease as a risk factor in this? Now, one of the things is this, that we were very true to the data. The data that we got at the initial time from the health check, which actually talked about, whether the patient has pre-existing coronary artery disease or not. That is where we actually took the data and analyzed and looked at it. This model predominantly talks about primary prevention. And now we are moving into secondary prevention when somebody who is already have an event or somebody who has a CAD, how do we go about and look at it? This is the research that we are currently doing, and Shiv sir will talk about it more in terms of how we are doing this, bringing in ECG and all that. Vijay will also talk about it, in the way that he perceives it and what we are doing in that way. But then the idea was to be in the very beginning, we were very true to the data that we got and kept it in our inclusion, exclusion, and doing it. So you might have some limitations while you use it, but that's how we have been able to do this. Sir, any comment on that? Yes.
Yes, I get it. The whole idea here was that we were looking at primary prevention in a seemingly absolutely normal person who walks into a health check, maybe at the age of 30 as a pre-employment or as part of a corporate health check or anything for that matter. So people who have had a coronary event are already established risk factors, and they go into the secondary prevention mode. And this is something which is we've been trying to clarify for a lot of physicians, as in why are we not including those with history of coronary artery disease in the AICD? Now I think it is absolutely crystal clear. Thank you, Sujoy. So, like Sujoy said, Dr. Shivkumar, the most important thing here, what we are looking at is how do we adapt this into our clinical scenarios? Where do my patient who walks in says, okay, am I part of the bigger spectrum? Am I part of just family genetically hand over the coronary artery disease, or is there something more which is happening in my life which is contributing to my risk factor, even if it is a low risk factor?
Has covered the major part of it. Primarily, this AICVD is started as a mass screening tool. So that's the primary objective is the way we do the pap smear to rule out the CA cervix.
Yes.
Similarly here, the AICVD, you asked why it started. So I can go back into that whole thing and tell you that way back in 2017, that was my thought process. That basically you needed a primary screening tool, whether does he have any apparent or hidden CAD or not. So once we do that, then of course in the score itself, we are categorizing into low, intermediate and high risk. And also there we are mentioning if you're falling into a high risk or intermediate risk, what are the things to be done? Like as Vijay is coming out, that's a fantastic thing. Probably the person who's in intermediate and high risk, probably we should start doing, in addition to the treadmill and echo and all those things, we should start doing a calcium scoring, because coronary calcium score is again going to be a very, very big determinant of that. Probably the other details like LPA, homocysteine and all those things, we can start going into that. And that's how we can stratify the risk. And broadly, we can catch them early, and that will help us to stratify the overall population per se into whether they're into low, intermediate, or high risk. That's the fundamental idea behind the ICVD.
Yes, absolutely. I mean, I think we cannot reiterate it as many times because it's like we demonstrated in the earlier thing, that how easy it is to just generate the risk score. Yes, interpretation is something which will probably be a little more nuanced, little more individualized, depending upon the person. So how do we explain the discrepancy between the accepted score and the actual score? I mean, say for example, like in the case we showed, no Vijay, that this person's actual score is supposed to be acceptable score is 5, but the risk score is coming to 7, and it varies between different people. I'm not sure how many of our health check patients you would have seen with this type of a difference, but we can run you through. We sent a profile, also a couple of profiles in which we see these differences, and the patient asks, the guest will ask the doctor here, like, okay, it's saying 7. It is saying moderate, but maybe if you are going to stratify, you are saying it is high. So how do we bridge this? I mean, how do we explain that what is acceptable and what is the actual score? One. Second, how do we say that, okay, it shows moderate, but as per me, this is high risk? How do we explain this? How do we explain this discrepancy? Because you are the people who are facing the patients out there. You need to unmute, Vijay.
Okay, sorry. It is the acceptable score is a person of same age and sex, and if they don't have any other risk factors. Suppose even if you see your pooled cohort estimator, if you just enter your details, they give you a risk based on your whatever parameters you entered. And if there is no risk, the same age and sex, if you don't have those risk factors, what is your acceptable risk? The same way, ASVD score, that also gives 2 parameters. One is if you don't have any of the risk factors, so what is your score? That is acceptable score. And what is your current score? So that is how you stratify them to different risk categories. So each one, because a score not going to be 0 for anyone. So it is a 0 means everything is normal. So there is to be always a score. Say suppose a 70-year-old, and if the chance of developing, if it doesn't have diabetes, hypertension, and all no smoking. So the chance of developing 2%, suppose you take an MI, and a person which has diabetes, hypertension, the chance of developing is 10%. So that is how that acceptable score and your score. That is how we interpret it. And that is how we tell the patient to convince. Suppose your score is high, then you have to get into lifestyle modification, all the primary prevention therapies. So that is how we have to convince the patient. So it is obvious with this acceptable score and what is your actual score. And sometimes again, none of the score is 100% accurate. So
yes.
But we are looking for a score which is 70 to 80% accurate. We have, even if you take a Framingham the score, then predictive ability is about 60%. So overall, and if you have something more than 70 or 80%, that is what the good diagnostic test, right? So that is what we are looking for. And none of the scores will be 100% accurate. But the ABCD scores, if you see the area under curve, I think that is the best for any of the scores so far as been shown in clinical studies. And when you have differences, and you have to again just go through the other parameters, and that is where the additional tests come into role. So whether you want to do a CT, whether you want to do a carotid imaging, that is how the additional test comes in. Imaging for subclinical atherosclerosis or a stress test, all those things come into this. And then again, the problem we face is convincing the patient to take medications. That is the major problem. Even you write and queue, as a physician, you would have seen they just take it for 1 or 2 months, then again come back. So that is where the challenge comes. But again, if you at least you see the red color in this, no, not yellow, red color. At least they are at least more, and a lot more the number of red dots you see in your muscle checkup. At least you are a little bit motivated to take that. That way, I think color coding helps. Red, green, and yellow. So yellow means okay, I'm bit on the other side. But if red means obviously you have to be very careful with this thing. So that way, then that is where the additional test we were talking about earlier. Just make them convinced to do a calcium score. Say that you just show them that you already have a problem. You take medicines properly, and again you show his HbA1c value, show his blood pressure value, and you show LVH on your echo. Fortunately, most of our health checks have an echo, ECG, and other things. Just show that already you started have a developing problem. So as you convince diabetic patient, you have microalbuminuria. Already you have your retinopathy. So that is how we convince the patient. You tell them you are going to lose, where you tell them that you're going to lose your vision, they definitely take medicines properly. You tell them you're going to lose your leg, definitely they take medicines. So that is how sometimes we have to be very blunt with the patient for that way to go.
Right. Thank you, Vijay. So, when we talk about extra testing, so for example, my question is to Rahul here, that say, for example, somebody comes with a moderate and a severe risk score, and we say, okay, your treadmill is maybe equivocal. What extra imaging we will add? And maybe at this stage in Indian scenario, do we add these to calculate the actual risk score? Maybe the coronary arteries will be normal, but still the risk score remains high. How do we explain that?
So I think it's always a combination of clinical history and the data. So we look at how vulnerable our patient is to develop a particular disease. So all these scores, this is more objective test, which is telling us how to proceed. As I told you in a busy practice, it will give a objective evidence. And I think Dr. that our patient, if we have some kind of coding, some kind of values, that is what motivates them to take further interventions. Now coming to say moderate risk, high risk, I am taking the history of the patient, which is also suggestive of if the patient is at high risk. I would definitely ask them to go for further CT score and maybe go ahead. Suppose. So it will all depend upon what the patient history also is. So patient history is, I'm doubtful about the symptoms and all. I would like to go for sometimes angiography directly. Sometimes I would advise them CT coronary angiography where it's equivocal. That you are not sure based on the symptoms. Neither you can rule out completely that this patient doesn't have anything. So CT coronary angiography has got a very good negative predictive value as far as the coronary artery disease has to be ruled out. So I will go for more advanced test. I would have lesser threshold in patients who have got higher risk scores based on the artificial intelligence calculated AI CVD scores. So that's how I'm going to utilize this score in my day-to-day practice in all these patients. It's like medicine is called as art and science. So we have some scientific evidences. The art is to dig out the history from the patients, because sometimes the patient's history has to be dug out. For example, some patient might say, I walk for 1 hour every day, but they are walking at such a slow pace which cannot interpret. So I ask them, how brisk do you walk? And sometimes these patients who come for fitness, they say, I walk for 1 hour every day, I'm comfortable. But when you make them walk on the treadmill, they are hardly barely able to walk. So what I'm trying to say is the combination of the clinical data, as we say, art and science. So we have the data which is available, the scores are available, and then we use the history and we dig out the history to find out what kind of further evaluation this patient would be needing.
So the AI is giving you the science and the art is with the doctor's talk. How you talk to the patient.
We have to dig out. Sometimes they're just hiding and they're not coming out, and then you keep on asking question, and then you realize that this patient has definitely. So I think that is important.
So the one thing which we are actually missing out here is using this AI CVD risk score as part of our care continuum. So in ProHealth, we have something called as care continuum, in which we have health mentors sitting out of various places who are picking up these scores and talking to the patient. But the adaptability of these scores, one, by the clinician themselves, so that it reflects in the health mentor dashboard. And then we are reaching out to the guest and the patient to see, like Sujoy said, that if somebody is coming down from high to moderate to low. I mean, I would want Dr. Shivkumar to answer me this. Like, what can we do to enhance our, how should I say this? Enhance our use of this AI CVD risk score as a very good tool to ensure that we have a very good care continuum program. Any suggestion from you, sir? Because we are really falling short here. I mean, diabetes is haunt, obesity is there, hypertension to some extent, yes. But the AI CVD risk score and the cardiovascular risk stratification is something which we have not been able to achieve yet. So I'm asking from the experts.
Basically, I feel that we need to do these type of webinars more and more, probably sensitize all our medical fraternity. Basically, because I started at saying that, we doctors always think that AI is something like a computer software. It is going to give us that whole concept, and the thought process needs to be little changed. And it's not like that, something we put it and something will come out, because I know few of my colleagues said, मैं डालूंगा ही machine में तो कहाँ से आएगा? So it's like that. It's like arrogance or whatever you can call it. So I think if I would say one thing here is that please do remember the machines can think. Okay. Deep learning is going into that way where machines can think, where human intelligence, human interruption can be avoided, and it can come out with its own results. So it's better for all of us that we start adopting it and start using it. Otherwise, I'm afraid, because AI is literally taking over all other spheres in the world, whether it is aviation sector or whatever sector you call, it's an AI which is dominating it. Medical field, it is still on a very nascent stage. Cardiology is the only one which is coming up. I can share certain things that the advancements have been done in AI are phenomenal, are mind-boggling. A person reading just eye retina. In China, they have done a study of 34,000 patients where they have seen that the coronary disease stenosis could be found out by just seeing the retina through an AI model. So it is going up very high. So coming back to your point is, I feel that we need to do more of a webinars. We need to sensitize people about the need of AI, and it is a friendly tool. If we can adopt it, it will be much more useful, and we can show the results also. As Sujoy was telling, very soon we are going to come with the AICVD 2.0 model, which will actually be way beyond than what we are doing it at this moment of time, because a lot of other things we are going to include. Of course, it will take some time for that whole model to develop, because it's a tough task, but it is. And similarly on other fronts, like in heart failure prediction, I can tell you that, we would be able to do that, those who are asymptomatic heart failures, because the biggest admissions in any hospital is because of the heart failures. And HFpEF, that is a preserved ejection fraction, the mortality is as bad as HFrEF or the reduced ejection fraction. But we would be able to make that diagnosis much before advance, well in advance, only by just ECGs. So that breakthrough, Sujoy, will come out after certain times with the publications. But yeah, we are in those things. But my only point is, kindly, I'm ready to travel anywhere if you want me, because I really want our colleagues, our medical fraternity to understand this and sensitize about the need for this. And once they adopt, I'm sure they will all use it in a day-to-day
I
practice.
think Dr. Shashikant is there. Yes, Dr. Anusha, hi.
Hi. So, Dr. Sujoy, very interesting. Like, training a model is one aspect, but testing it against the external cohort is another thing. So, very happy to know that your paper is coming out. So, two questions. One is, I know paper is going to come out, but what are the some things that, since you are on this panel, that has come out of this research, like key probably the point. The second one is, the whole discussion about why we have developed this score is because of the Indian demographics, right? But like you also mentioned that the score is being used even in the UK, etc., etc. So how is it faring in others? So one
yeah.
part is whether in South Asian or Middle East and Southeast Asian countries, and the other is like in the Western countries. Is it relevant there?
Fantastic
Yeah, thank you.
question, Dr. Anusha. So, the first thing is, I just want to go back to the old discussion what Shiv sir was mentioning. Adoption is a very key in all of these, and adoption is key because of the forward learning that we have through the adoption. So now, there are 5-6 questions that Vijay asks me or other cardiologists ask me as to, why am I seeing this low score in a person who already have coronary artery disease? Now, those are the kind of things that we want to understand it from a statistical perspective, from a mathematical perspective, from a computer